My name is Hooman Soleymani Majd, and I'm a consultant oncological surgeon at Oxford University Hospital. And today I'm going to take you through when and how to preserve fertility in gynecological cancers, a paradigm shift. Ability to conceive can be affected by cancer treatment. Some women with a new diagnosis of cancer might have already compromised fertility potential, which might deteriorate further by cancer treatment. Women do bear emotional and psychological burden during their ordeal, and there are short and long-term consequences of surgery. There are toxicities and side effects associated with chemotherapy or radiotherapy, or the combination of both. Every year, over 22,000 women are diagnosed in the United Kingdom with the gynecological cancers. Every day, 60 women receive this life-changing news. Approximately 15% of them are between the age of 15 and 39. Fortunately, 80% of young cancer patients will survive their treatment. Uterine cancer by far is the most common gynecological cancer we treat and is deemed to be on the rise, as obesity is considered to be the main culprit, and we're going to face a global pandemic. Approximately 12% of all patients with endometrial cancer are younger than 50 years of age, and the United Kingdom prediction is that 50% of women will be obese by 2050. We strictly adhere to national and international guidelines when it comes to the management of these patients, both written by British Gynecological Cancer Societies and also European Surgical Gynecological Oncology bodies. Is fertility sparing an option for endometrial cancer? Standard treatment for endometrial carcinoma in women is total hysterectomy and bilateral salpingo-oophorectomy. Hysterectomy increases chances of surviving the disease, but this treatment is particularly catastrophic for young premenopausal women who will no longer be able to carry a pregnancy. Fertility sparing treatment in endometrial carcinoma is an option for a subgroup of women, but should exclusively apply in earlier stage and non-metastatic disease. Patient evaluation should take into consideration reproductive potential and also risk factors that affect the capability to carry a pregnancy successfully, including the status of the uterus. We carry out a very comprehensive pretreatment workup. We call this the circle of truth, that we do take and ascertain the full history of fertility issues. We carry out imaging, and in the uterine cancer cases, we do MRI of pelvis with contrast. Then we discuss with the patients the pros and cons of conservative management, the failure rate, the success rate, and the live birth. We then try to manage the patient expectations, and patients will then be able to make a decision about the treatment. The treatment will then be carried out in an environment which is supportive of the patient's care. It's very important that you carry out these consultations with the presence of cancer nurse specialists who are pivotal in the patient's journey and the pathway. We do in Oxford and have access to reproductive specialists who are gynecologists, who are subspecialists in reproductive medicine, who will see these patients preoperatively to assess them about their fertility potentials and carry out all the basics and advanced tests, including antimullerian hormone and follicle counts, and also calculating the day to 2 to 5 FSH. Remember, some of these patients are already suffering from polycystic ovary disease, and they do have compromised fertility potentials. Then, if you identify any obstetric issues, these patients will be then referred to preconceptual high-risk obstetric clinic. Then they will see the fetal medicine specialist who will discuss with them the pros and cons and risks of pregnancy. To whom can treatment be offered? So we do offer these treatment for women who would like to preserve their fertility, but they have to have a favorable tumor biology. Patients with G1 or well-differentiated endometrial adenocarcinoma who are stage 1A with no radiological evidence of myometrial invasion, we do offer them. When it comes to moderately differentiated or G2, this may be offered, but it has to be done very carefully in large tertiary centers. So G2, a stage 1A endometrioid adenocarcinoma, could also be treated, and also well-differentiated endometrioid adenocarcinoma with minimal myometrial invasion of 1 or 2 millimeter. Patients with the Lynch syndrome, as you know, 3% of women with uterine malignancies have Lynch syndrome, and 1 in 280 of people we see carry this genetic predisposition. So when it comes to the Lynch syndrome, you have to be careful because patients with the Lynch syndrome might have a different response to conservative management, and the failure rate and the success rate would be variable. Also, 1 out of 3 of these women could have synchronous or concomitant ovarian cancer. Hence, you have to be cautious. You would never offer conservative management to patients who have high-grade tumors or what we call aggressive tumor biology. Examples of those are clear cell, mixed carcinosarcoma, high-grade serous and G3 endometrial adenocarcinoma, or mesenchymal tumors of the uterine body like sarcoma, leiomyosarcoma, or adenosarcoma. Now, we are practicing our the management of the uterine cancer in an era that we have full access to molecular profiling. We do encourage to perform the promised molecular classifier in all young patients with grade 1 and low-grade endometrial carcinoma who wish to preserve fertility. We do immunohistochemistry for 4 important subtypes of these molecular classifiers, and we do know the patients who benefit from the conservative management are patients who are P53 wild type or P53 normal, who have the best response to progesterone treatment. We try to avoid these type of treatment for patients who have aggressive molecular classifier like PP3 abnormal or aberrant, and also for patients who have MMRD, which is mismatch repair deficiency. For patients who are poly ultramutated, we do not have extensive knowledge about this, and the applicability or the practicality of these molecular classifiers for this subtype is not yet very clear, but we do know that we will have more information in years to come when it comes to patients selection. Now, how do we manage these patients? There are growing evidence of literature that we are able to resect this earlier stage low-grade endometrial adenocarcinoma by hysteroscopic approach. In fact, Yvonne Mazzone published a paper with Professor Scambia and described the 3 steps that we could be exercised prior to medical treatment. Basically, in step 1, you will have a thorough assessment of the uterine cavity, and then you will take mapping biopsies. And in step 2, you will resect the lining of the womb or endometrium with 4 to 5 millimeter margin. And in step 3, you make sure that you get 3 or 4 millimeter off the myometrium, so you have not, or you will not miss any disease underneath. A very interesting and comprehensive systematic review and meta-analysis was published by Zhao in ACTA last year, and this looked into the oncological and reproductive outcomes of endometrial atypical hyperplasia and endometrial cancer patients undergoing conservative therapy with hysteroscopic resection, which it shows that this would improve the chance of treatment and also success rate in achieving better results and a better live birth. So how do we treat? The most common treatments we use are oral progesterone. We either use medroxyprogesterone acetate, which is 400 to 600 milligram daily, or megestrel acetate 160 to 320 milligram daily. We could also use intrauterine LNGIUS with a dose of 52 milligram. This could be done either primarily with medical treatment, which is using the progesterone, or you could exercise a hysteroscopic resection with LNGIUS. As I said, there are growing evidence this actually works really well. But I think this should be done in a center with a great deal of expertise in managing of these patients and a very experienced hysteroscopist to be able to identify these tiny small areas of malignancy. Duration of treatment is 6 to 12 months, within which a complete response should be achieved. Then we will keep these patients under surveillance, and the surveillance will be on a 3-monthly and pattern or fashion, and we will obtain biopsies. After 6-month proven regression, patient could consider pregnancy or continue with maintenance treatment. The success rate of conservative treatment is around 76%. The live birth is around 26%, and the relapse rate is 26%. And these three numbers are very important figures to have in hand when you see these patients in clinic. We also know that the weight loss during fertility-sparing treatment is highly recommended, and that it increases the chance of response to treatment. And it could positively affect the live birth rate. Some patients might choose to have lifestyle changes or bariatric surgery, but as you can see, there are papers who are extremely supportive of those changes and those lifestyle changes which will change the outcome. The second most common cancer that we see, which require fertility preservation, of ovarian cancer. Ovarian cancer is normally a type of cancer which presents quite late. In fact, 4 out of 5 of patients present in late stage, hence we will not be able to offer any fertility preservation or any approach to preserve the fertility organs. But among all ovarian cancer, 12% are diagnosed in fertile women. Remember that the incidence of ovarian cancer is 1.3%, which is 1 in 70 of women we see. Again, we do carry out the same pre-treatment workup, which is very important. Full history of the patients, look at the fertility wishes of the patients, comprehensive discussion of pros and cons of conservative management, and then management of course patient's expectation, and patients will be the one who will make the decision. As I said previously, with these type of patients, you need to carry out numerous consultations. Often they have more questions which you will be able to answer through your cancer nurse specialists who are with you during these consultations. Again, these patients will be referred to fertility specialists who will decide whether these patients would benefit from having ovulation, induction, and egg retrieval, or perhaps ovarian preservation when it comes closer to the time of the operation. And again, if we identify anything which is remotely worrisome, we will seek out advice or reach out to our subspecialists in fetal medicine who will be able to guide these patients preconceptually to optimize their status and increase the chance of conceiving without any problem. As I said before, there is no fertility sparing for women with bulky ovarian disease. And sadly, most patients do present, like these photos as you could see, with advanced disease, that this high-grade tumor has completely infiltrated and invaded the gynecological organs, including the ovaries, tubes, and the uterus. Hence, these patients will never be chosen or recruited for fertility preservation. These patients do require radical surgery, debulking, and chemotherapy. We normally offer fertility preservation to patients with the borderline ovarian tumor, stage 1A, 1C, 2, 3, malignant germ cells grade 1, and in patients with epithelial ovarian cancer if they are stage 1A, G1. So basically, it's very important to, when you offer this type of operation, first you have to make sure not only radiologically, but also surgically, you are satisfied you're dealing with the earliest stage. So European Society of Gynaecological Oncology Fertility Preservation Task Force highly recommend that the patients who are chosen for fertility preservation should have low-grade tumor, like G1, G2, and they should be like endometrial adenocarcinoma of the ovary or mucinous, but they should be low-grade or borderline. And these patients should be fully and completely a stage. We do offer this patient laparoscopy or laparostomy, full assessment of the pelvis, upper abdomen, and all quadrants. Then we carry out unilateral salpingo-oophorectomy peritoneal washing, peritoneal biopsy, pelvic and parotid lymph node dissection, and then we send this for the final histopathology, and then we would know whether these patients are truly early stage before we continue with the fertility preservation approaches. It's very important these patients to get, if they've been diagnosed with the earliest stage ovarian cancer, to have unilateral pelvic and parotid lymph node dissection up to the renal vein, plus minus contralateral assessment of the pelvic and parotid node, as they do harbor cancer cells in the retroperitoneal spaces, especially retroperitoneal lymph nodes. Now, there's a question of whether minimally invasive surgical staging, earlier stage ovarian cancer, is as good as laparotomy. But we need to remember that we're dealing with women who are very young, and of course, large midline laparotomy scar is not very appealing to these women. We know perhaps open surgery might be quicker. We know that intraoperative complications are similar in both laparotomy and laparoscopy arm, but we do know that the patients who have had minimal access surgery, it's very likely that they will be discharged earlier, and they will have a nice smooth sailing the post-operative course and less chance of having blood transfusion. So minimal access surgery in early stage ovarian cancer has been done, and it happens. But one thing which is very important when it comes to minimal access surgery in early stage ovarian cancer, we have to be really confident that we follow the oncological hygiene and we try to avoid any tumor spillage, because in order to do a minimal access surgery in ovarian cancer, you have to make sure the disease is completely confined to the ovary, and when this ovarian tumor or mass is removed, it has to be retrieved through the endobag to avoid the spillage, because the spillage would compromise the patient's outlook and fertility. And we do know that by rupturing the cyst or surgical spillage, which is in fibrous staging, is the stage 1C1, you will compromise the patient's outlook. So it's very important whenever we offer fertility preservation in ovarian cancer, we make sure that we have the right sets of skills and make sure that we avoid spillage, and everything has to be retrieved through the bag without any exposure or contamination. Now, the third cancer which we tend to offer fertility preservation is a cervical cancer. In fact, cervical cancer is the most common gynecological cancer in the reproductive age group. And unfortunately, despite screening program which we have in place and the HPV vaccination, we still see patients coming through the screening program or unexpectedly with cervical cancer requiring treatment. The incidence in the reproductive age group in the cervical cancer is quite astonishing, as these women are typically under the age of 45 and are planning or going or embarking on pregnancy. We have witnessed trends in delayed pregnancy over the last few decades, and fertility-sparing surgery is quite important. When it comes to the fertility-sparing operation, we need to be mindful of the changes FIBA introduced in 2018, which would have some implication and have had some implications in early stage classifications. We do know now the lateral extent of the carcinoma is no longer considered distinguishing between the fibrous stage 1A and 1B carcinoma. And if margins of loop are involved, this is allocated to a stage 1B. Hence, since the introduction of these new changes, we are carrying out more loop excisions to be able to make sure that we are dealing with the right stage before we offer any treatment. The question we ask is what algorithm we would use for the management of these patients, and this is what I use and we use in Oxford. Firstly, we offer fertility preservation to women who only have cervical tumor less than 2 centimeters. The histological type of these tumors should be favorable tumor biology, like squamous cell carcinoma, adenocarcinoma, or adenosquamous. And we have to have radiological evidence of early stage. And for patients with a stage 1A1, if they have lymphovascular space invasion, we organize the MRI. We typically exclude tumors which have poor prognosis and they have aggressive tumor biology by nature, like clear cell, glassy cell, adenoid cystic, neuroendocrine, and carcinoma. For a stage 1A1 patients who would like to pursue fertility preservation options, we offer them conization and large loop excision of the transformation zone. And if they have lymphovascular space invasion, or what we call an LVSI positive, we either carry out sentinel node biopsy or systematic pelvic lymph node dissection. We need to know that the lead specimen should be a non-fragmented one with a 3-meter negative margin for cancer. For a stage 1A2, we offer conization or cold knife. We prefer to avoid cold knife with or without sentinel node or pelvic lymph node dissection, depends on the availability of the local expertise, or we could offer simple trachelectomy with or without bilateral pelvic lymph node dissection or sentinel node biopsy. For patients who are between a stage 1B1 to 1B2 to 2 centimeter, these patients do require radical trachelectomy with pelvic lymph node dissection, or with or without sentinel node, or with para-aortic lymph node dissection. Again, that would be dependent on the local protocol, but for larger tumor, we do require to offer radical trachelectomy. Now, we are living in an era that we know that we have learned in the last 20 years, and this has been extrapolated from the evidence which emerged from the role of sentinel node for breast cancer, melanoma, or vulvar cancer, that we are now getting more and more comfortable following carrying out the sentinel node biopsy for vulva and the uterine cancer, doing more for the cervical cancer. The first study is almost 20 years, Cervical 1 and Cervical 2, and now Cervical 3 is in this way, showing that women who undergo sentinel node biopsy will be less likely to face the consequences or the grave consequences of systematic lymph node dissection for the rest of their life, like lymphoedema. And also ultra-staging with the sentinel node and the serial sectioning and immunohistochemistry detects low disease like micrometastases, and also isolated tumor cells, also known as ITC. For these women, again, we stick to our circle of trust, which is a full and comprehensive pre-treatment workup. Our approach to patient's care is holistic. We take a full history of understanding what the patient's expectations are from going through these type of fertility preservation. Remember, all these fertility preservation options are alternative to the main treatment. They're not the main treatment, especially these early stage cervical cancers, for example, are really curative. So a patient needs to have full understanding of the pros and cons of these approaches. We have to make sure we exclude other existing uterine malignancies, for example, hyperplasia in patients who have polycystic ovary syndrome or raised BMI, and also manage the patient's expectation. Again, patient makes the decision about the treatment, and they will remain to be at the heart of this pathway. Counseling is very important with the presence of our cancer nurse specialists. As I said before, they are pivotal in the patient's pathway. And of course, reaching out to our fertility specialist team who are able to carry out the standard preoperative and comprehensive workup about whether these patients will be eligible for fertility preservation. The operation we offer to these patients is called trachelectomy, and trachelectomy is a Latin word. Tracheles means neck, or cervicectomy. Basically, by that I mean we remove the cervix, the tumor, the upper part of the vagina, and the tissue or the neighboring tissue. So this is called paracolpium or parametrium. And when the tumor is excised with the neighboring tissue, then we will re-anastomose the uterine body back to the vagina. Cervical cancer has gone through significant evolution, I think, from being really, really aggressive at the beginning of the century. We're getting now to the point we call it de-escalation basically going to do this operation with a less and less aggressive manner. Professor Schatzer was a pioneer of the total vaginal radical hysterectomy, followed by Professor Bertine, and it was Professor Danjon who did the first trachelectomy, vaginal trachelectomy in 1993. The first abdominal radical trachelectomy as a new surgical technique for the conservative management of cervical carcinoma was published in BJOG in October 1997 by Smith, followed by the first robotic assisted abdominal laparoscopic radical trachelectomy by Person in Gynaecological Oncology Journal in December 2008. And then we saw the first publication of Fertility, sparing laparoscopic radical trachelectomy for young women with earlier stage cervical cancer by Kim in February 2020. So these operations have been carried out over the years by means of abdominal route, robotic, laparoscopy, and vaginal route. A very large meta-analysis and also National Cancer Database paper published by Barossa Chu, looking at the trends in use and survival associated with fertility sparing trachelectomy for young women with early stage cervical cancer. This paper was published in June 2018, and it showed that between 2004 and 2014, more than 15,000 patients were diagnosed with cervical cancer, and it showed that 97% of patients had hysterectomy, but 3% had trachelectomy. But it showed that the trachelectomy rates more than doubled in 10 years. And the greatest rise was seen in women under the age of 30, showing that younger women have been reaching out to preserve their fertility. It also showed that 1/3 had tumor more than 2 centimeters, and it was very informative. The other paper published by Enrico Bentivegna in Lancet Oncology, Professor Philip Morris, assessing over 3,000 of patients, comparing 6 different fertility sparing procedures, identified that in the vaginal radical trachelectomy group, the recurrence rate and tumor size recurrences was much higher in women who had tumor more than 2 centimeters. In fact, showed that if the tumor is less than 2 centimeters, the risk of recurrence is around 4%. But if the tumor is more than 2 centimeters, recurrence is more than 17%. Hence, the tumor size more than 2 centimeters should be a contraindication to radical vaginal trachelectomy. Then, in November 2018, Professor Pedro Ramirez and Professor Anders Overmyer led a paper called Black Trial, which is was published in New England Journal of Medicine. This was minimal invasive versus abdominal radical hysterectomy for cervical cancer, which showed that women with the cervical cancer should not be treated by means of laparoscopy, as it's 6 times more likely to die if the approach is by minimum access routes. They went on also, Gloria Salvo and Pedro Ramirez led another paper called IRTA, International Radical Trachelectomy Assessment, to see whether we're able to identify the same findings. But as you know, we have not carried out a phase 3 prospective study comparing the laparoscopy versus laparotomy for trachelectomy, but this study was a retrospective multicenter looking at 535 patients to see whether women with the cervical cancer could be treated by means of laparoscopy if we preserve the fertility. Again, this study was hindered by low numbers to determine if there is in fact a difference given the lower number of events for recurrence in this patient. Hence, again, not only a definitive treatment should be encouraged to be done by laparotomy route, but also fertility preservation should be carried out by open approach rather than laparoscopy. So how do we do this operation? I'm just going to take you through the classic steps of nerve sparing radical abdominal trachelectomy. The way how we do this on the left-hand side, you can see we open the pelvic side wall, we identify the ureter, and we sling the ureter, and we preserve the round ligament because this is a fertility preservation operation. Then we carry out systematic pelvic lymph node dissection. In the middle photo, we can see the external iliac vein and artery have been medialized from lateral to medial, and we have identified the obturator nerve. This is an obturator fossa. As you can see, this nerve is L2, L3, L4. This is a nerve which supplies the adductor longus magnus brevis, and this is where you might be able to find a positive node. So you have to remove all these lymph glands, and this is the final appearance of the pelvic side wall when these nodes have been removed. This could be done either by means of systematic lymph node dissection or frozen section, or sending a node, but we do send these nodes to the lab for frozen section before we carry out the rest of the operation, because we have to make sure we're not dealing with any disease before we preserve the uterus. The next step is anterior and posterior colpotomy and the measurement of the vaginal cuff from the central tumor bed and identification of the 2 centimeter clear margin. You can see here that the cervix has been identified and the tumor around it. We have clearly identified 2 centimeter clear margin. The round ligaments are slung away, including the pelvic vasculature and the ureter, and we measure that precisely. As we do know, we want to do this right and get this right with the first go. We don't want these patients to come back with a clear margin or requiring further treatment, so we get that all organized. And then what we do is the complete detachment of the cervix, vaginal cuff, paracolpium, and parametrium from the vagina, from the distal vagina. The instrument of choice, or my favorite instrument, is LigaSure. This is where we try to preserve the ascending branch of the uterine artery. We come back in a retrograde fashion, similar to Hobson. We sacrifice the descending branch and the cervical artery. We mobilize the parametrium on both sides, and we identify exactly the cuff we would require. When the tumor is completely excised, we insert a Hegar dilator of 8 into the uterine cavity through cervical os and apply the cerclage, which is the insertion with O-proline. Then, after this is done, we will tie this proline over the Hegar to make sure it's quite secure. And when it's done, we will replace that with a Foley catheter and fill it up with the saline. This is where we do and complete the operation by performing a uterovaginal anastomosis and the formation of the neocervix. And this will be done with the interrupted number 1 artery posteriorly and anteriorly, and then we will release the slings afterwards. What is very important about the radical trachelectomy is when we see these patients, and we discuss this with our junior doctors as well, that you need to have these figures on the top of your finger so you can discuss the pros and cons of these operations. It's very important to mention to these patients we're a well-selected group of patients. 5-year survival is around 95%. The recurrence is between 4.2 to 5.3%. And if these patients are recurred, 90% of these metastases are local and 10% are distant metastases. And 10% of them would require to have adjuvant treatment. There are some complications associated with trachelectomies and fertility preservation of the cervix. The most common one are the psychological impact and anxiety it could cause. This patient might have abnormal cervical smear, which affects around 60% of the patients. They might have dysmenorrhea, irregular bleeding, hyperuria, dyspareunia. They might require to have cerclage revision. They might get stomach stenosis because of scarring and fibrosis. Lymphoedema, we talked about the role of sentinel node to prevent this. And infertility, which will affect a quarter to 50% of these patients. And also obstetrically, they might face recurrent miscarriages, premature preterm matrix membrane, preterm labor, increased perinatal morbidity and mortality. And also, if these babies are born prematurely, they might need to be admitted to a neonatal unit. And think about the neurodevelopmental delay. And these patients always required to have C-sections, hence this needs to be effectively communicated with the highest obstetricians and the fetal medicine team and perinatologists before even the pregnancy has happened. That's why we send them to see our colleagues in the preconception clinics. Now, this is a question I get asked all the time. How do we monitor these patients? There are all sorts of guidelines out there about the optimum surveillance. These are the combination of colposcopy and HPV testing with a smear. 5 was suggested in 2018. They need 3 to 4 monthly follow-up for 2 to 3 years, and 6 monthly up to 5 years, and annually for life. ESGO suggests the same frequency, but also they suggest return to population-based screening. However, duration of follow-up can be tailored depending on the risk of recurrence or persistence of treatment-related complications. So my practice, or what we do in Oxford, is for year 1, we see them in a colposcopy clinic every 3 months with HPV testing, and we organize an MRI as a benchmark. And year 2, 4 monthly, again with HPV testing, smear, and annual MRI. And from year 3 to 5, we continue with 6 monthly assessment of the new cervix and upper vagina and HPV testing, but MRI would be contingent upon the patient's circumstances and the symptoms. And of course, if not pregnant, we can follow them up for 10 years. We do not routinely offer completion surgery or completion hysterectomy, as it would not alter the outlook for patients who have completed their family. What about the patients who have tumor more than 2 centimeters? There are some studies suggesting that we could perhaps consider neoadjuvant chemotherapy prior to fertility sparing surgery for a larger tumor, but I would invite everyone to adhere strictly to the suggestion and recommendation of British Society of Gynaecological Cancer that women who would not normally qualify for fertility sparing may be considered. And also, if you want to use this, it has to be done within either the audited or within a registered service evaluation project or in a clinical study. So you have to be very careful not to routinely offer neoadjuvant chemotherapy to this patient and try to find and register them as part of ongoing trial. There's some known trials out there. One, again, Mario Blunt and Professor Federica Mon. The trial is called Contessa and Nikon. These are the studies that are trying to identify whether the outlook of these patients with the neoadjuvant chemotherapy is going to work. But the results are awaited, and we have to wait until 2025 and we can have the interim analysis. But there are people who are trying to identify the answer to this question through prospective studies, which is very important. The other problem that we face every now and then is the cervical neoplasia in pregnancy. This by itself is a very long, could be a very long lecture, but in a nutshell, if women present between 16 to 20 weeks with a cervical cancer, we tend not to delay the treatment, and depends on the stage, they either get surgery or chemotherapy. But for women who come from 20 weeks onwards to 24 weeks, as we're getting closer to the age of viability, then we can consider the options of delaying the definitive treatment, which is a valid option, or depending on the patient's expectation, we could consider surgery or fertility surgical approach. And if the patient has advanced disease, again, the discussion around chemoradiotherapy with the intention to cure needs to be carried out. This is a very complex matter. Cervical neoplasia in pregnancy does require a multidisciplinary teamwork, not only with the gynecology, oncology, MDT, but also with medical oncologists and also clinical oncologists and also obstetricians who are in charge of the patient's care. The communication is the key to succeed, to come up with the best management for these type of patients. And neoplasia in pregnancy is a very sensitive subject requiring a great deal of expertise. Now, the question we ask ourselves, can we go less radical? This is very important. Less than 1% of patients with early-stage cervical cancer will have parametrial disease. So this is a paper published in 2011 led by Professor Pedro Ramirez, suggested that women who are low risk or earlier stage might not have any parametrial disease. And since then, remains to be a question which we now have found the answer. The first paper published in 2021 called CONSERVA Study, which was a prospective trial of conservative surgery for low-risk earlier stage cervical cancer, showed that we could be less aggressive. In fact, we can de-escalate our surgical approach to women who are low risk. In this paper, patients who were recruited by squamous cell or adenocarcinoma grade 1 or 2. Histology was a tumor less than 2 centimeters with no LVSI and the depth of invasion less than 10 millimeters. Trial did show that conservative surgery with conization and simple hysterectomy is feasible in patients with earlier stage low-risk cervical carcinoma. The rate of positive lymph nodes was 5% and the two-year recurrence was 3.5%. Then last week, very much awaited trial led by Marie Gland from Canada, published in New England Journal of Medicine. This trial is called SHAPE trial, which has assessed and compared simple versus radical hysterectomy in women with low-risk cervical cancer. This trial showed in patients with low-risk cervical cancer, simple hysterectomy was not inferior to radical hysterectomy with respect to 3-year incidence of pelvic recurrence, and in fact, it was associated with a lower risk of urinary tract morbidities like retention, bladder or urinary tract or ureteric injuries. So this now has endorsed the CONSERVE trial, and it has shown that the time has come to think about de-escalation when it comes to the radicality of surgery in cervical cancer. In a summary or in a nutshell, fertility sparing surgery for cervical cancer could be offered through laparoscopic, robotic, vaginal or abdominal oral routes or with simple conization. But we need to be mindful of the study which I previously mentioned, the LAC trial, and which has been adopted by NICE guideline, suggested that women with cervical cancer should not be treated by means of laparotomy unless the patients are recruited as part of trials. And I think what we're going to see in this group of patients, they will probably be receiving conization or the second or third local sentinel node, and the radical trachelectomy will be kept for patients who have a bigger tumor. This has now been supported by CONSERVE study, and last week, of course, the SHAPE trial published in the New England Journal of Medicine, which I encourage all my colleagues to go and read in depth. Now, in conclusion, I would like to say patients can be reassured that fertility-sparing surgeries are oncologically safe, and there are good chances of subsequent pregnancy in earlier stage gynecological cancers. Fertility-sparing surgery should only be done in centers that offer all techniques. So you need to have all the resources in your armamentarium, and you have to have a solid and robust MDT who is able to offer all treatment options. Holistic, patient-centered care is paramount and should be under the auspices of the MDT. Patients will remain to be the center of this pathway, and continued support and consultations with the patient and the family is the key to succeed. Many, many thanks for listening to my talk.
So Professor Soleymani asked us, Christian, Becker and myself, whether we would actually just add a little tiny bit at the end of his very informative talk about a service which we in Oxford are very lucky to have. And I would just like to say, obviously, in the next few minutes, we don't have much time to tell you about this. And so it may be that it would be a good thing for us to do a full ground round at some stage. But in the light of what we've just been talking about, Oncofertility has become a really important and emerging service and program throughout the country. And as we cure more of our patients, we need to think about their long-term survival and how we're going to ensure that the quality of their life is as good as we can possibly make it. And of course, fertility sparing surgery is very important, but it's one of a number of things that need to be thought about when you're talking about fertility preservation for children and young adults. In 2013, with the guidance and support and everything you can possibly manage to try and get a new program up and running, Professor Kennedy, Professor McVeigh, Professor Becker, and Professor Lacou all helped in forming the program that we have here in Oxford. So why do we need this program? And the important thing is that all cancer patients should actually have a discussion about fertility at the beginning of their journey along the treatment. It's really important. Patients tell us that oncologists are very good at curing them from their disease. Fertility experts are good at talking about fertility treatment, but none of them have the full picture. And so Oncofertility means joining up all the dots and having oncologists, fertility specialists, your specialist surgeons all working in together, which is what we do here in Oxford. So just to quickly say why we need this. Well, infertility is the most feared late effect after cancer treatment. And many young people cannot live their lives to the full because of the fear, the depression, the anxiety about infertility. It causes huge isolation. You don't put it on your social media that you've suddenly found that you're in premature ovarian insufficiency at the age of 20. It's enormous lack of self-worth. Who's going to love you once you've actually not only had cancer, but actually now you're infertile? When do you tell people about that? On your dating app, as you walk down the aisle after 2 years of trying to have a family? It causes enormous amounts of mental illness, which is something that if we can do only to help that aspect of it, we've achieved an enormous amount. You're 40% less likely to have a family compared to your siblings if you have if you have cancer as a young adult. And probably one of the most horrific sort of statistics is that of those patients cured of early young adult childhood and young adult cancer, 1 in 5 who find themselves infertile consider suicide, because it is just such a difficult thing to live your life. So if we're going to cure patients, we have to really think hard about what it is that we're going to be able to give them in the future. Christian, could you give me the next slide? So the patients who are particularly at risk, as Professor Soleymani has explained, are those obviously who are having surgery that's going to remove either their ovaries, their uterus, damage the cervix. Clearly, that's a high risk sort of activity. But on top of that, if they're going to get certain types of chemotherapy, that will destroy their potential for fertility. So if we haven't thought about it up front or very early on, then having fertility sparing surgery is going to require them to, at the very minimum, use donor eggs, which is a potential possibility and one we need to talk to patients about. But we need to have these things in mind. Radiotherapy. Now, many patients, if they have pelvic radiotherapy, will be having 40-50 gray of radiotherapy, or brachytherapy in cancer of the cervix. As little as 2 gray is very toxic. You lose 50% of your ovarian reserve with as little as 2 gray. So radiotherapy is very toxic. There are many patients who have cancer treatment which is not gynecological, but which will involve them having these sort of treatments. And we need to be able to talk to these patients upfront about how we can help them to have a family in the future, either using their own eggs, their own uterus, or with other means. And this is a conversation that needs to be right up front, almost before you're at a point of having, just when you've got your diagnosis, you need to think about it so that we can have time to help them before they need to start their treatment. Next slide. What can we do? Well, obviously, there are various options you can think about. You could think about using medical treatment such as GnRH analogues, Zoladex, that sort of thing. The evidence for that is not strong that it helps with fertility. It will stop you losing blood and therefore reduce your need for transfusions. It's not going to damage your fertility, but the meta-analysis over the last 30 years has showed that really this is not a good method of fertility preservation. It may add a little, but it's not going to give you the best outcome. Cryopreservation, that's freezing your gametes either as mature eggs or tissue for women or sperm and tissue for men, are the mainstays of how you can actually preserve the gametes. That each and every patient, we have to consider all of the factors that are going to make that safe, potentially possible. Storing eggs will take at least 3 weeks from the moment that we actually get informed about these patients. We can random start them, but they still need to have that period of time. So you have to have a window when you can offer these things. Tissue requires a general anaesthetic, so you have to be physically well enough to be able to go through that. We have to think about whether it's physically possible to either retrieve eggs or to get tissue which is not going to be contaminated with your original cancer. Because if we're going to use this tissue, particularly if we're going to use the tissue, we need to be clear that it's not got metastatic disease. The eggs, we don't want to cause spread of the cancer by inadvertently going to collect eggs in a area that's contaminated with cancer. So many considerations. And what I would say is the earlier that you can ask for a consultation for your patient, the more likely it is we can help them to see that there's hope for the future and that fertility is something that we're actively working along. Christian? Just to say that at the moment, the 2 main centres for the whole range of fertility treatments, that's tissue, eggs, etc., Edinburgh and Oxford. We started our programme in 2013 and we are actively now, NHS England is in the process of commissioning this service, so it will be fully funded. And we hope that this is something, therefore, that patients across the UK will be able to be offered in a way which gives them the opportunities they should have for the future. Christian?
I think I'll take over now briefly. So thank you, Sheila. Just for the last 5 minutes or so, I just wanted to give you a little bit the surgical side of this. I'm very honored to be part of this team. Kokila Laku, who's on the call here today as well, she's done a lot of these operations herself. So there are 2 things we have to consider. One is the ovarian tissue removal, and there are 3 options available. One of them is either to take a ovarian biopsy, to do a partial oophorectomy, or a unilateral oophorectomy. So when we do a laparoscopy, and this is obviously in an adult person, when Kokila operates on these children and very young children, sometimes half a year old or a year old, this looks anatomically very different. The ovary is tiny. We have to decide what we do. And when we started the service, we first decided to do tissue from the cortex, which is where the eggs are located. And some bigger units around the world still do this. They take biopsies from both sides. Because the argument is that when they want to put tissue back, you need a platform to put it back to, and the ovary is obviously the best place because of blood supply and location. We tend to take a single ovary out nowadays to really minimize the risk of bleeding, because we're always a bit worried that there's some bleeding after the patient wakes up from this wound, although other groups have said that this is not so much of an issue. There is obviously the possibility of collecting eggs directly from the ovary, so similar to in an IVF cycle, but obviously these patients didn't have enough time to go through IVF, and therefore the majority of these eggs are immature and therefore cannot be fertilized yet. But through a process called in vitro maturation, you could collect some of these eggs and then mature them in tissue culture and fertilize them afterwards, which would circumvent the the issue of retransplanting cancer cells eventually. It has not worked as nicely as we had hoped, but it is definitely something that should be investigated further to help our patients. So when we then put tissue back, again, 3 options. One is orthotopic, so towards the or into the remaining ovaries or ovary. Heterotopic in the pelvis, peritoneal pockets, or heterotopic outside of the pelvis. As Sheila alluded to earlier, we have to make sure that, or minimize the risk that we're not transplanting cancer again. For example, patients who have leukemia, they have a much higher risk of having cancer cells in the tissue. These patients often have 1 or 2 cycles of chemotherapy before we take the tissue out to get a bit of cancer clearance, but there's still a high risk or relatively high risk of retransplanting tissue. At the moment, we're not putting that type of tissue back from these patients. Some groups put representative pieces of the frozen tissue into nude mice for 6 months, and if they don't develop leukemia, then they think they have enough support to put some of the tissue back into patients. And I think the verdict is still out there, so we're very careful at the moment. The first successful retransplantation was reported in 2004 by Jacques Donnet's group in Belgium, in Brussels. But as you can see in the middle, they actually had to transplant tissue twice. The graphs here show the hormone levels going up, and that's usually what we use as well after the transplantation. We measure the FSH levels, which should go down once the ovaries start producing estrogen. So you have the negative feedback there. What we do when we put tissue back, and we've done this now in, I think, 9 patients. Here you can see on the panel A, this is an ovary where a piece of tissue was missing, so someone took a biopsy, and then you can open that a little bit further because the medulla has all the blood supply, and then you can plaster the little pieces of tissue on top of this. And then here, in this case, we put surgery cell on top of it, and then a little bit of fibrin glue, and that holds very nicely, so it doesn't fall off. On the lower panels, you can see a peritoneal pocket. Again, the whole point is you need a blood supply that does it quickly, because the vast majority of follicles that are in there die off during the first week or so, until there's a proper blood supply getting to the tissue all the way through. If you do orthotopic outside of the pelvis, there's people thinking, well, why do we have to go into the pelvis? Why don't we put it somewhere where it's accessible? For example, here, this is a group in the US where they put something on the forearm, and you can stimulate that tissue, and you can see on the left side, if you look closely, there's actually a follicle growing under the skin. Unfortunately, it hasn't been successful yet in creating any babies. Now, we have been putting tissue back, as I said, I think 9 patients so far, and we've had 3 children and 2 ongoing pregnancies at the moment. So it is very successful. Apart from 2 patients, all of the patients had their endocrine function return, and that can last for many years sometimes. 1 patient hasn't, and that was a patient who had radiotherapy to the pelvis. So we are now about to retransplant tissue somewhere outside of the pelvis, and hopefully the blood supply is better there and will be more successful. So as Sheila said, potential future fertility problems and fertility preservation treatment options should be available to all patients, should be discussed with them, the pros and cons, and there are options for all patients. So please seek advice, contact us. We're available through the Fertility Trust. And this is the end of the talk. And if we still have some time for questions, please do.